All right. Good afternoon, everybody. It's Galya Chinnery from Groot, and I'm going to be trying to give you a topic which I find quite difficult. But first of all, it's always our job to thank everyone. So just so that you are reminded, G-ECHO is hosted by the Gastro Foundation in association with Project ECHO from the University of New Mexico. And this G-ECHO Forum for the Fellows runs every Monday, 4:30. Feel free to pop up any questions on the chat and I will try and answer them. We'll see. But let me go to screen share and then we can take it from there. Okay, if someone, Karen, can you just confirm you can see the screen?
Yes, I can see the screen, thanks.
Fantastic, thanks. Then we'll get going. So this topic is difficult for me in that it's one of those things where there isn't a clear answer, and I think it's gastroparesis from a patient's point of view, obviously, but also from a clinician point of view, it's unsatisfying to treat. No clear answer, no management plan really works for absolutely every symptom. So let's just take ourselves through it and perhaps we can come to a solution for this specific patient of mine, which made me actually think of doing this topic. Let me just hide there we go. So to start off, my present clinical problem is a very well 32-year-old lady. She reports to me that she's had a couple of admissions, a couple of times a year, and it's always very similar, severe abdominal pain with significant gastric distension. She almost looks pregnant, she says. And this actually requires admission and physical decompression by a gastric tube. And then every time on her scope, she's got a giant big full stomach with old food and contents. After every meal, she reports early satiety and just generally always an ongoing, uncomfortably bloated kind of feeling. She's not someone who's putting on. She's an active lady, works well, is a keen hiker. She's actually planning a trip up Kilimanjaro. So it's not that she's trying to, I don't know, she's a fit, clear-minded woman, if I can put it that way. This is her other plain film x-ray, and you can see just how impressively large that stomach is with that rather large air fluid level. But also you do see that there's quite clearly good air in the rest of the small bowel. So there's no absolute indication that there's an obstruction here. Just one last image as well. This is from the barium swallow. Apologies, so barium meal. And again, you get an impression of this rather large, very distended stomach. But again, after some time, there is definite flow throughout the entire small bowel. But perhaps you'll agree with me that that small bowel is just on the upper edge of normal. I do think it's a little bit dilated, but that's perhaps just me. And then here, just a quick run through of her CT scan, which was obviously done to exclude anything else, any other pathology. But again, you get a good appreciation of a really large stomach filled with fluid and bits of retained food, and no clear indication on either the CT or the endoscopy of any form of obstruction. The scope flies through beautifully. There's honestly absolutely nothing. The other thing I would have considered perhaps is an annular pancreas or something. But yeah, the duodenum looks beautiful. There's really nothing much to be seen. So let's chat a bit about gastroparesis. What is the definition? Well, I think you'll all agree, you know it's a syndrome of delayed gastric emptying, and this has to occur in the absence of an obstruction, and they do present with an array of associated symptoms which can be more or less for different people. As you can see, satiety, which Our Lady has, postprandial fullness, nausea is a big thing, vomiting. Bloating is obviously also an equally big thing. And then occasionally abdominal pain is quite on the forefront as regards presentation. The other interesting thing here that there's definitely a predominance of gastroparesis among female patients, up to 4 times as much. And this is a study, this is a finding that's been reflected in multiple studies. So that's quite interesting to note. So 4 times as common in females. Then this is just a slide to indicate to you the most common pathologies. And I must confess that I always thought type 1 diabetics to be a more common cause of gastroparesis, but it's definitely actually type 2. The average age for presentation of gastroparesis is around 40. However, if you're a type 2 diabetic, then it ups the age a little bit, and the average is then around 53 years. So what are common causes? We've mentioned diabetes, and then idiopathic and post-surgical states. Those are sort of the big 3. But medications which decrease gastric transit, really you have to look for those and specifically ask for them. And some of those common culprits are opioids, oddly enough, some antibiotics, antiarrhythmics, and anticonvulsants. And yeah, obviously it makes sense that neurological disorders and connective tissue disorders can be involved in the pathogenesis of gastroparesis. I'm not quite sure in my mind how viral infections play a role, but perhaps it's a little bit more like the background pathology that we think of as regards achalasia. Maybe it's similar with the degeneration of the neurons, must be. But yeah, so those are the common causes to look for, but the big 3 are mentioned on top. So as regards diagnosis, you need the typical symptoms, no mechanical obstruction, and you must somehow confirm delayed gastric emptying. I don't know if those of you that were able to attend SAGES, but Prof. Sechedi also gave a talk on gastroparesis, and she really went beautifully into the diagnosis and various forms of tests that you can do pre-confirmation of your diagnosis. And I do suggest if you wouldn't mind listening to that, it's really quite useful. I'm going to summarize the diagnosis rather, and then focus a little bit more on the management options. But please remember one thing, that the retained gastric food that you see on scope or on the X-ray images is suggestive, but this cannot be used as a diagnosis. So you need a little bit more. So the gold standard by all indications remains gastric scintigraphy. We do not have any of the alternatives mentioned here available to us, but should you have them, then obviously breath tests, wireless capsule motility or impedance are also quite reliable. EndoFlip, I'm not aware of anyone at the moment in South Africa or any of the sub-Saharan continent having this, but I might stand corrected. But that's also quite useful as regards impedance. This is a list of things which is not necessary and actually not recommended. So the full thickness biopsy, that's out of the window. Radio opaque markers also out. Doing manometry distally of the antroduodenal area, also not really useful. EGG, maybe a bit of more work needed. And then PET-CT, also not really useful. MRI falls into that group. So if at all possible, if you've got one test to ask for, it's gastric scintigraphy. That's the one to go for. So let's assume that's been done. It has actually, to be honest, been done in my patient, and that confirms gastroparesis. So just so that you know, and we also did the CT, as you know, in the swallow. Now, gastroparesis as regards symptoms can be categorized as mild, moderate, or severe, pretty much similar as the Eckhart score, in that you look at the scoring of various symptoms and you judge them as regards their occurrence rate. So the severe group will have daily continuous symptoms, multiple visits to the casualty departments with or without admissions, to such a point that it's interfering with their work and functioning significantly. Then for gastroparesis, like the Eckhart score for achalasia, there's the gastroparesis cardinal symptom index daily diary, which is pretty much the same. And the symptoms that are usually dominant, I mentioned them briefly, but nausea is by far the most common, irrespective of your cause of gastroparesis. The pain part of it, interestingly enough, is more presenting in those with idiopathic gastroparesis when you compare it to diabetic gastroparesis. On the flip side, you get more vomiting in patients with diabetic gastroparesis, which is strange. That I can't explain. Maybe somebody can tell us at the end. Early satiety, postprandial fullness, that's about in 2/3 of patients. And then the other quite frequent complaint is bloating. But nausea is obviously at the top. So what about the pathophysiology? Everything comes down to the interstitial cells of Kajal. These interstitial cells of Kajal, as you know, are the gastric pacemakers, and they generate or are responsible for generating slow waves of smooth muscle contractility towards the antrum at roughly 3 cycles per minute. In gastroparesis, there's a depletion of these interstitial cells of Kajal throughout the stomach, but more prominently, it appears to be a deficiency in the area of the pylorus. Then, in addition, quite a few studies have shown increased smooth muscle fibrosis and decreased enteric neurons as well present in gastroparetic patients. So you've all probably seen a wave of peristalsis propagating forwards in the stomach at some point. And if you're new at endoscopy, you can sometimes confuse that with the pylorus. But how is this propagated wave of gastric contraction actually all coordinated? So a lot is at play to get these waves organized. And the interstitial cells of Kajal and the pacemaker region are localized to the upper gastric body curvature area, and these are responsible for starting off a successive wave. And as it propagates forward, I've just drawn this green here sort of to assist with the idea of as it propagates forwards, downwards towards the pylorus, the speed is roughly 3 millimeters per second. But it makes sense because of the length of the greater curvature, the longer length of the greater curvature, that as it propagates along the greater curvature, it has to be a bit faster, such that you actually get a circumferential wave. So a bit faster on the greater curve. Then the antral wave actually accelerates to 7 millimeters per second and even faster. So this explains why even with a widely patent pylorus, if you've got no proximal contractility, with that latent elasticity of the stomach, it'll just distend like a sock that you've gone hiking in for 3 days. I haven't changed it. So this is my personal opinion. This is why, to me, purely addressing the pylorus in true gastroparesis has potentially disappointing results, because you're not actually, because of the shape of the stomach being that funny kidney bean shape with a distal emptying, you are not, without waves of contraction, going to get a very successful emptying process happening if you've not got proximal contractions. So that's just something to bear in mind. As mentioned earlier, this combination of fewer neurons, interstitial cells of Kajal, and the smooth muscles with an increase in fibrin, they're all confirmed on full thickness biopsies. And whatever you sit with at the end looks like this big giant sock. Plus, you get a hang of a lot of stasis and reflux upwards. So let's focus now on what do we do with this poor lady. Your treatment options, as with anything, are non-invasive, minimally invasive, and then the more invasive side of things. Let's discuss firstly our non-invasive options. So I think the first things are obvious: small, more frequent meals, try to stick to low fat and low fiber content. And then it becomes an issue of deciding which pharmaceuticals might be appropriate in the individual situation. So genuinely useful pharmaceutical agents are not so, they're a bit limited in gastroparesis. And interestingly, the only one that's actually approved by the FDA in the States for managing gastroparesis is Maxilon, metoclopramide. However, the problem comes with metoclopramide if you use it for longer than 12 weeks. That long duration increases the risk of developing tardive dyskinesia, which, as you know, can be irreversible. So yeah, I think Maxilon has its uses, but again, it's a temporary thing, and most of these patients are suffering for many years. Domperidone is another prokinetic with a similar mechanism of action. It's equally effective, and apparently the lower side effect profile should make it more a favored drug. However, the prolonged QT ratio is an important potential adverse effect. So you do need to regularly check the ECG. But there's been several studies that have been done as regards domperidone safety, and they report quite good effectivity and safety despite this QT concern. So that's an option. Erythromycin, which is something we will grab at and give quite frequently. As you know, it acts as a motilin receptor agonist. It works, but again, the effectivity decreases with time due to downregulation of the motilin receptor. Then the sort of standard antiemetics, prochlorperazine, promethazine, and ondansetron, they've got some benefit. As you know, we've mentioned previously that the nausea is a big thing. Vomiting, less so, but still. And then there's some good reports of selective 5-HT4 receptor agonists, such as prucalopride, showing some promise in this clinical scenario. I'm not sure, I might be mistaken, but I'm not so confident that we actually have this available. So I don't know how useful that is. So what about minimally invasive? And there I've put the 3 options, endoscopic options: Botox, pneumatic balloon dilatation, and stenting. None of them particularly work. So stenting, first of all, let's start at the bottom. Not a great long-term idea due to the really high risk of migration of these stents. There's no stricture. Despite the fact that you've got no propagating waves from the top, from the stomach side, the motility of the small bowel, duodenum specifically, that stent will migrate. So not a good option there. And again, yeah, thinking back of the camping sock, I don't know how well that works. Pneumatic balloon dilatation makes absolutely no difference at all. So you're wasting your time there. Botox, let's just spend a quick word on Botox. I think Botox makes us feel better, to be honest. You know it's not invasive, you know it's not permanent, but there is potentially that bit of placebo effect for both the clinician and the patient, I think. Us personally, we do use it occasionally following specific situations, and that is with a gastric tube pull-up following an esophagectomy, where you know that we divide the vagus nerves, and you do have, in some patients, delayed gastric emptying that doesn't improve in the time period that it normally does. So then we do inject Botox. But I must be honest, I suspect it works mainly because with time going by, that stomach, it doesn't have an interstitial issue with cells of Cajal or anything like that. So it does start emptying by itself slowly again. I don't think so much because of the Botox, but it's something we do to make ourselves feel better. As regards pyloric Botox in gastroparesis, there are a couple of retrospective studies which have shown a little bit of clinical benefit in the short term and some symptomatic improvement. But again, it wears off, obviously. And more importantly, there were 2 quite nice randomized placebo-controlled studies where they gave some none, some 100 units, and some 200 units, and it made absolutely no difference in those situations. So for the present moment, the ESGE does not recommend Botox in the scenario of gastroparesis. So I think that's something we should take home. You're wasting your time, basically. So GPOM, new kid on the block, pretty much something that has shown to me to have some improvement. I personally have not done a GPOM, but I think in principle, it's similar to an esophageal POM, where, as you know, the first thing is to do a mucus incision so that you get in between the layers, muscles on the outside, mucosa on the intraluminal side, and then you burrow yourself a tunnel, pretty much like with a POM, I imagine, using spray coagulation, which is what we prefer. And then the only difference is they start 3 to 4 centimeters from the pylorus. With a normal POM, we obviously start much higher up. And then the tunneling and the identification of the pyloric ring, which you can see down here on the image here, pretty much occurs as per standard POM. And then the myotomy is, as far as possible, a selective circular myotomy. So, yes, there's improvement. It appears to be safe. It's effective as regards a minimally invasive option. And it should be reserved, however, for refractory gastroparesis. And especially they are recommending GPOM for patients with a predominant nausea, vomiting kind of clinical scenario, and also those specifically with a shorter duration of disease, regardless of the etiology. That is the kind of patient that hopefully may end up with some benefit following the GPOM. As you see, it pretty much stabilizes after 18 months. It doesn't improve after the first month. It is what it is. We're going to look at gastric electrical stimulation just now, but here too, you'll see that with time, it is the diabetic gastroparesis patients that respond slightly better than the non-diabetics. So that's the idiopathic specifically and the surgical group. So the diabetic gastroparesis do have a slightly better outcome. So gastric electrical stimulation, what everybody wants to know. What about it? Does it actually work? So let's talk a little bit about the apparatus itself. First of all, it's the trademark. It's registered and manufactured by Medtronic. It's comprised of 2 leads, a pulse generator, as well as a programming system. So the 2 neuromuscular leads are then placed 1 centimeter apart from each other within the muscularis propria of the stomach's greater curvature. So you're sort of aiming for that pacemaker area that we showed on the earlier image. And you try and put it at least 10 centimeters proximal to the pylorus. Then the pulse generator itself is positioned in the abdominal wall, usually either the right or the left upper quadrant. And then an external programming system will allow for different stimulation parameters. This system from Medtronic is called the Entera therapy, and it's high frequency, low energy settings, which can be changed. And fortunately, the battery lasts, they say, between 5 to 10 years. So that's the background to it. You can put it in via open surgery or laparoscopic. So I think important to know from the start, those patients that are expected to have a poor response to the system, you should avoid trying it. It's jolly expensive. It is an operation. So let's remember who shouldn't be getting it, or let's put it differently, those that are expected to have a poor response with a GES. So it's patients that come to you predominantly complaining of abdominal pain, anyone who's got an opioid narcotic history in the background as a potential confounding factor, and then patients with comorbidities such as migraines, and then obviously to me, anorexia, bulimia, rumination syndrome, cyclic vomiting syndrome. Those are obviously patients who need to see somebody else, not only a gastroenterologist. So those will be not someone you would send for a GES. The other group of patients are the patients with tachygastria. I'm not quite sure how you would go about diagnosing that, to be honest. And I think the take-home message here is if you've got a diabetic with refractory gastroparesis, they are the only group where it's really been shown to have some improvement in outcomes. So this is a very complicated algorithm, and don't focus too much on it, but it offers a reasonable approach to when you should or shouldn't be considering a GES. And you'll see in the middle here that I've circled in red that the pyloric intervention is the next step if your GES system has failed. And there's definitely better outcomes with the two. If you put them simultaneously, that's great. So that's actually prompted some to advocate performing the two together as a standard. And that does make sense. If you've got some stimulation from the top, emptying that baggy sock of a stomach of yours towards the pylorus, which is now way more open than before, you can see it in your mind that this is potentially going to work. But the one without the other, yeah, anatomically and in my mind, just doesn't quite make so much sense. So I would, if you answer in an exam, I would say the two together would probably give you the best outcomes. Just to be aware, of course, is that gastric electrical stimulation insertions are not without their own issues, and to be aware specifically of the complications. You can easily get dislodgement initially. Once they've settled and they've grown in and stuck there, then that's fine. But the dislodgement usually occurs early. You may get penetration of the electrodes that you've placed actually going through the gastric mucosa, which kind of is an absolute waste. That's not going to do any good. Your lead insulation can get damaged. You can get erosion or migrations of the neurostimulator itself, and then bowel obstruction. Not quite sure how that fitted in. And then obviously with anything inserted under the skin, you can get infection there. So not without issues. And as I said, some prefer to place them open so that they can get those electrodes really well situated into that muscularis propria area. Others will do it laparoscopically. So bottom line is, does it actually work? So we've sort of alluded to the fact that diabetics may have a better outcome, and diabetics with a shorter history of complaints. So this review article of the entire system, a systematic review, offered a word of caution, and I found it quite interesting. So I'm mentioning it to you. Take it as you will. It was written in 2015. They eventually ended up including 21 papers in this review. And although the evidence base is limited, they came to the conclusion that it does seem to offer improvement in quality of life and symptom control to a subset of patients, specifically diabetic. And they also mentioned some improvement in post-surgical gastroparesis. The results were uniformly poor for idiopathic gastroparesis. Now, here's the clincher. Perhaps interesting to note that of these 21 papers, 14 of the 21 were financially supported by Medtronic. Medtronic was responsible for the stats in one. One author is responsible for 12 articles, another for 5. So 17 of the 21 papers are written by 2 people. And the total number of randomized patients is just over 80 patients. 6 articles use the same hospital and the same time frame, so one assumes the same patient group. So I think you'll agree with me. What we really, really need to put this issue at rest is a really good quality randomized controlled trial. Now, the problem with that is it's not really ethical to go and place a sham GES system with the surgical risks and then just pop them into a placebo group. So it's a difficult RCT to actually get going. So what about blinded crossover trials? So two were reported in this systematic review. And they had basically what they did, they had two groups of patients, 3 months with their GES switched off and then on, and then vice versa. So one reported a single symptom improvement. Others showed significant improvement in both instances at 12 months. And this raises, though, the question of why there was such heterogeneity in the outcomes, even with the higher quality studies. So this suggests either the presence of other variables that contribute to the symptom reporting in the long term, or that short-term symptoms that are reported don't really correlate with the future outcome. So to me, this was a really excellent systematic review, but it sort of left me hanging. It didn't help me with the answer. So next one. This was another one written 2 years later. Again, looked at all the evidence that was out there. And for what they reported as their conclusion was there wasn't enough evidence for the routine use of GES stimulation devices outside of a clinical trial. And it also suggested that the longer the symptoms, the less likely an improvement was going to be seen. So that sort of fitted in with the short term that we had with the GPOM as well. So I think you can take home that, yes, the diabetics, there may be a bit of an improvement, short-term better response, but ideally this is not something we should be popping in once every blue moon. This should be in a trial situation. This is not for the the occasional GPOM insert, GES insert. I think that's unfair to your patient. So I think let's stop with the GES and we take home the following. It does seem to improve nausea and vomiting. There isn't an objective improvement in gastric emptying. There's an improvement in diabetics, and specifically in diabetics with a shorter duration of symptoms. And as we mentioned on the algorithm, the addition of a surgical pyloroplasty is something to consider. Whether you do that open or via GPOM is up to you what you are able to do. So I think there's some augmentation of symptomatic improvement, but the benefit of opening your pylorus is definitely there. So which one of the two is actually making the big difference? Not so sure. Let's look at the invasive options, treatment options. The surgical interventions include firstly, let's go through them slowly, jejunal tube placement. So that requires either a laparoscopy or an open procedure where you put in a permanent tube in the jejunum. That is something that doesn't really improve your quality of life. If you completely stop eating, well, that, only nibble and stuff, but you're still going to potentially have your gastric symptoms. So jejunal tube is essentially for nutrition and potentially to minimize the symptoms of vomiting. I don't know, not a great option in my mind. Pyloroplasty, we mentioned, you can do that surgically, open or laparoscopically. Pyloromyotomy and GPOM, we've spoken a bit about that. And the GES system we've mentioned, I've put that under invasive because that does need to be done with surgery. Then you get to the more involved permanent changes as regards anatomy. And that would include a Roux-en-Y bypass, partial gastric resection, and then finally for the absolutely refractory, very symptomatic patient, you might at some point get to a consideration as regards a total gastrectomy. Sorry, my slides are a bit mucked up. Here we go. So surgical interventions, please reserve those for rescue therapy in those who do not respond to medication. Oddly enough, as regards surgical pyloroplasty, a GPOM is superior than just doing a pyloroplasty as we would always do for a stricture. And I think that must be down to the fact that you're actually making a far longer incision than you would normally do if you were doing a stricturoplasty of a pyloric ring fibrosis. Pyloric intervention, they say, is superior to a surgical resection. I think that you would have to consider the individual and the size of the stomach that you're dealing with. I think if you've got a really enormous baggy full stomach and you're only opening distally, you might not have such a great outcome. So subtotal gastrectomy with a Roux-en-Y gastrojejunectomy, that's definitely an option. It works well. And then, as we said before, you can combine it. Refractory, total gastrectomy, and that's advocated as your last resort. So published outcomes for refractory gastroparesis are compared here in this systematic review, 2018. And they said that pyloromyotomy, pyloroplasty had a better patient symptom response than the GES. That makes sense. And weighing in by number of studies, the pyloric surgery improves nausea and abdominal pain better than the GES. And interestingly, GES vomiting is more likely to improve than abdominal pain. So yeah, something to consider. And I think the gastrectomy, although it's really quite an intense thing to do and to offer a patient, I mean, that's big surgery for essentially a rather benign condition. But if your quality of life is such that every waking minute is related to this gastroparetic stomach of yours, removing the offending organ sorts it out. It eliminates that gastric reservoir functioning that just keeps going. With that, your nausea is gone. With that, your bloating is gone, and the vomiting is gone. In addition, it removes the afferent neural impulses and hopefully, so it also affects the nausea and so forth. So yeah, I think we mustn't, the GES is awesome, sounds good in principle. And then if you add a G-POEM to it, it all sounds very fancy. But we're not picking up diabetic gastroparesis patients that have been with their symptoms for a year or two. These patients have been walking out for much longer. And then the outcomes are poorer. So I'm not advocating a Roux-en-Y partial gastrectomy for absolutely everything, but I do think it's a really good thing to keep in the back of your pocket for a refractory, very symptomatic gastroparetic patient. And the smaller the pouch that you leave, with a nice wide anastomosis, the better that emptying will be. There won't be much stasis. And the big thing for us as a surgical group to remember is that the rulum between your gastric anastomosis and your distal enterostomy must at least be 40-50 centimeters. Anything shorter, you're going to now create a gastroparetic patient with bile reflux. You can only imagine how awful that's going to be. So just be aware of that. So that length is important. So I'm going to leave you with this treatment algorithm, and I've popped in a few of my own additions. It's very busy and full, but let's look right down. We're not going to talk about the diagnosis and all the medicinal options. Let's go straight down to non-pharmacological, so basically your invasive thing. To reiterate, pyloric Botox, no, it doesn't work, okay? G-POEM, whether you do it or a laparoscopic pyloroplasty or an open pyloroplasty, yes, and that is an option. If you have a long-standing idiopathic patient, you may have poorer outcomes though. The Entero system or the gastric electrical stimulation, if you do offer it, there's enough evidence now to say that you should be offering with that a pyloric drainage procedure. And if you have the ability to do so, the one they advocate is G-POEM. Otherwise, you may as well offer them a pyloroplasty, but the two definitely have better outcomes together. I put a question mark here by the venting gastrostomy or feeding jejunostomy. I think if you're getting to the point where your patient is so symptomatic that you're decompressing essentially and feeding beyond the stomach, why on earth are you not offering them some form of resection and sorting out the problem? So to me, fair enough, I might be biased with a surgical approach, but in the refractory patient, long-standing with abdominal pain as a big thing, you're not going to win with the lesser invasive options. And I would consider offering them a subtotal Roux-en-Y bypass. But that's just me. The American College of Gastroenterology, this is their very nice algorithm. The red, please remember, is what I've added. May or may not be agreeable to them. I think these are added valued points. So back to our index patient. Gastroparesis, as I said, confirmed on scintigraphy, cause is idiopathic. She's got no other comorbidities. She does not take any medication at all. Pain and satiety are her main complaints, pain occasionally bringing her into hospital. So I think with this background, perhaps you'll agree with me, I would not waste time or the rather expense of the GES. I wouldn't do that. I don't think she's going to have a good outcome. She's also been symptomatic for about 10 years. So the question here is, to me, does she actually now start warranting a surgical intervention? It is a big stomach. Do we offer her a drainage or a partial gastrectomy? I'm not sure. I think for my intents and purposes, she hasn't potentially been optimally medically managed. So we'll give that a try for a few more months, see how she goes. Now, otherwise, I think I would offer her a Roux-en-Y bypass. But again, I'm open to suggestions. I think this is gastroparesis is such an uncomfortable situation for the patient, but such an unsatisfying solution from our side. So yeah, I hope that leaves you with some things to think about as regards gastroparesis. A word of caution about GES, and if you are considering it, do add a pyloric procedure to your placement of the GES. I think that is the way to go. But generally, a little bit more disappointing, those results, than one would have hoped. So thank you. I don't know if there's any questions. Just looking at the chat. Yes, so Gert says, remember that glycemic control, also super important, as that can cause delayed gastric emptying. Absolutely agree. And he's confirmed that prucalopride is not available. Thank you for that. So yeah, Gert, thank you for picking up the dilated small intestine. So I didn't tell you one thing about her, which I think is going to play an important role, but I didn't want to confound the talk I was giving. But she's been previously diagnosed with achalasia and treated as such with a balloon dilatation. So now you've got two organs that are an issue. Potentially the small bowel, I agree with you, doesn't quite look right. So does she not have a generalized issue, not just localized as the referral letter to the stomach? I would agree with you. Yes, absolutely. Okay, I don't see anything else. Okay, Karen, are you happy I close up? I don't see any more questions.
Hands up from anyone if there are any other questions. I think you've covered everything then, Galya. Thanks very much.
No, I think I have not covered everything because nobody really knows the answer. So that's the problem. But it remains for me to thank you all for joining us this afternoon, and to thank ECHO UNM as well as ECHO India for their support. There is a feedback form if you wouldn't mind filling that in. And then the recordings of all of these talks that happen on Monday afternoons, as you know, and hopefully are using, are available on the Gastro Foundation website. And obviously, again, thanks to Karen as well as the Gastro Foundation for arranging all of this. And to advertise, next week it's Stefan Hofmeyer from Tygerberg, and he's going to be taking us through bile duct injuries. And that's got some more clearer answers than gastroparesis and should be quite interesting. So thank you for your time and have a good evening. Bye-bye.
Thank you.